TB is still the leading cause of death in South Africa. Each year, approximately 55,000 people contract TB and tens of thousands develop multi-drug resistant TB. In 2012, government announced new strategies to fight this scourge. Are we making any progress? Well, stay with us because today we focus on TB and more specifically drug-resistant TB. Our expert panel will help us understand the complexity about this disease, how to prevent drug-resistant TB, and how it's treated. We'll also get an update on the much-awaited TB vaccine development. And for any questions or views on this topic, please call us on Johannesburg 714-6843, 6847, or 6857. Or interact with us on our Facebook page, SABC Health Talk, and on Twitter at SABC Health Talk, including our email address, healthtalk@sabc.co.za. I'm Dr. Sello Mutaung, and this is Health Talk.
It has been 50 years since the world developed a new TB drug. Manufacturing new TB drugs for low-profit areas with no investment was not attractive. Today, the tide has turned. The BCG vaccine is an early intervention. Increased cases of TB drug resistance led to a collaborative effort to find solutions. Medical scientists were exploring alternative vaccines and medication. Today, delegates are discussing the prevention, detection, treatment and management of TB.
There are some new vaccine approaches that in animal models have shown incredible results. These include CMV vectored vaccines. CMV is a virus called cytomegalovirus. And so there are other candidates that are being fast-tracked to get into the human as soon as possible.
More than 1,400 new TB cases are diagnosed in South Africa every day. This has raised the alarm of non-governmental organizations in South Africa.
In HIV, the tide was turned when eventually HIV was recognized for what it is, a threat to life on a massive scale, requiring a response on a massive scale. We need a similar response to drug-resistant TB.
We're once again seeing a number of new drug compounds emerge. There are some very promising drugs. One of them is called bedaquiline. That's currently in the process of being approved by our Medicines Control Council. Another one that imminently might become available is delaminid, which also already has conditional approval in Europe and the United States. Paradoxically, it's approved there and not here yet, because this is really where we have the biggest burden of disease. And there are other drugs, for example, linezolid, that can be quite effective, particularly for drug-resistant strains that are available in this country but not registered yet for tuberculosis.
South Africa is the third leading country globally in TB infections. The TB conference has ended. What is the way forward?
All right, to help us understand the extent of this TB and MDR TB burden, we welcome our special guest. First up is Dr. Lindiwe Mvosi, who's director in the TB Control and Management Cluster in the National Department of Health. Welcome to Health Talk. And next to her is Dr. Sarah Baba, who's the WHO's representative to South Africa. Sarah, welcome to Health Talk. And we also have Dr. Norbert Njeka, who's director MDR TB and TB and HIV in the National Department of Health. Welcome, Dr. Njeka.
Thank you.
All right, now, I suppose people know what TB is, but perhaps let's just start there. Dr. Mvosi, what is TB and how is it spread?
TB is a disease that affects mainly the lungs, but it does also affect other parts of the body. It is spread through the air. When a person coughs, the mycobacterium come out from the lungs and into the immediate surrounding of where the person is. And anyone within the vicinity of that person is likely then to get infected with TB. But when you get infected, you might develop disease immediately after infection, or you might contain that infection and not develop disease for a long time. Right. It all depends on the immune system.
Okay. I know that, it's quite common, Dr. Njeka. How does someone know that or suspect that he or she might be suffering from TB?
Yeah, TB is a disease that loves the lungs, loves oxygen. Mm-hmm. So the commonest form of tuberculosis is pulmonary tuberculosis. So cough is really the first symptom. They will be coughing, they'll be sweating at night, and then there's a problem. And later you'll have loss of weight and many other. But cough is really the main symptom.
Okay. Now there's this concept of latent TB. Please just take us through that, because we need to just understand how it develops into MDR TB ultimately. Just take us through that concept, please.
Latent tuberculosis is a situation whereby a person is infected with the TB bacilla, but they've not developed active disease.
Right.
Because when you talk about TB, in general communication, lay people's language, we're looking at active tuberculosis, actually. Right. But most of us who were born and bred in Africa have contracted this condition probably before we went to preschool, or maybe when we attended preschool or primary school. Yeah. So we have this condition, and it's quite within us. And when you got trouble with your immune system, then later you can develop active tuberculosis. Mm-hmm. So it's very common, far more common than active tuberculosis, which we call TB commonly.
Okay. Dr. Baba, we know that, there's reports that, South Africa is really up there when it comes to the burden of TB and MDR TB. What is the extent of this burden throughout the Southern African region?
Well, tuberculosis is the second leading cause of death from infectious diseases after HIV. So it's a major cause of death and sickness in the African region. We have, as you mentioned earlier, we have 9 million new cases occurring globally, and 30% of those cases are occurring in the African region. So it's quite a major issue for Africa as a whole.
Dr. Mvusi, what is the extent of this problem in South Africa?
Well, the problem in South Africa is quite huge. We're reporting more than 300,000 people every year who have TB and are treated for TB. And here in South Africa, we see that it's driven mainly by HIV, with high co-infection rates at about 62% nationally. And there are 4 provinces, actually, that are contributing the largest numbers in terms of TB in the country, which is KwaZulu-Natal, Eastern Cape, Western Cape, and Gauteng.
Why is that, though?
Well, it's mainly due to the population size in those provinces, and as well as HIV prevalence. Again, in those provinces, we know that KwaZulu-Natal has the highest HIV prevalence. And poverty as well. Those are the major drivers. But we're now seeing people with diabetes as well getting TB, and as with the increase in diabetes, we are seeing an increase in TB as well.
It's a ticking time bomb. Yes. Dr. Jega, we're talking about TB in general, but what seems to be emerging now is multi-drug resistant TB. What is the extent of that problem?
Multi-drug resistant tuberculosis is really a threat to tuberculosis control in general. While we think that numbers of drug-susceptible TB are coming down, Dr. Mvusi just said now we treat more than 300,000. We used to report 400,000, yet WHO estimates that we could be having 500,000 people having active TB every year in South Africa. Now, 2% of new TB cases every year would be MDR TB. We're seeing more MDR TB.
So essentially saying the graph for MDR TB seems to be going up, and that for general TB is coming down somewhat.
Beginning to go down, yes. And there are reasons for that.
Yeah.
2 reasons mainly. Yet a lot of people are worried. You see, drug-resistant TB or MDR-TB is seen as a failure to control tuberculosis early. So a lot of people
A failure on whose side, though?
Well, failure in the health system in general to control tuberculosis. But in this case, I think my understanding is that we're diagnosing more than before. We got a laboratory capability here, which is very strong. Hence, we're seeing what has been there. It's not like this. There's a bit of increase, yes, I agree. But with more tests, like expert, we used to take, 3 months before we know a person has MDR-TB. Now we know within a few days and put on treatment. Hence, our numbers have doubled since we started expert. So for me, yes, there's an increase, but we now know what we didn't know before we got this new technology.
Right.
So we should be happy numbers are increasing, because I don't think they will decrease before we get to exhaust them, find them all, or most of them.
I'm not so sure about the being happy part, because when you have more MDR-TB, I mean, it surely is a strain on the system. I mean, Dr. Baba, for instance, let's perhaps look at the financial impact that this burden is having on countries in general.
The financial impact from MDR-TB is very important for a normal TB or what we consider a normal TB patient. The course of treatment can cost anywhere from $100 to $500 US. But for an MDR-TB patient, the course of treatment can cost up to from $10,000 to $50,000 US. So I think that the costs are very high. So it's something that we do have to address very aggressively to prevent an escalation of MDR-TB patients.
Yeah. Dr. Bush, I mean, people with TB obviously need to be on treatment. Okay, I suppose those that are on are ambulatory, taking treatment, at their homes and clinics and so on is probably understandable. But when it comes to MDR-TB, these people need to be admitted for long periods of time. What sort of impact is it having on the healthcare system, the public health sector?
Well, the impact is mainly, again, on costs, because hospitalization does cost a lot of money.
Yeah.
That is why now the Department of Health is looking at decentralizing the management of patients with MDR, and at least getting them to be treated at facilities nearest to their homes.
You just hold it there, because I want us to take a little more on that. But for now, we're just going for a quick commercial break. When we come back, we'll continue our discussion on MDR-TB. Stay tuned.
People, we are getting there, and thanks to you, Pati is set to become our country's 12th official language. Here's today's word: substitute, replacing a drinking buddy with somebody more fun.
That has gone out of the ballpark.
That's more like it.
Raise a castle and save a rhino. Get a top pack for only $76.99. Tops at Spar. Shake things up.
Cameroon's economic capital, a unique art collection is on display. Titled Yesterday's Memory, Tomorrow's Memory.
We are trying to preserve this heritage despite many things that have changed in the designing, embroidery and the model.
If I'm telling you, you don't like it, I call it defeat.
Join Musam Khalifi on Afro Showbiz every Saturday at 19:30 CAT.
Now, there are people within our communities that are more vulnerable to contracting TB The government has, over the last few years, prioritized these communities. Let's learn a bit more about these from our guests, Dr. Lindiwe Mvusi, Dr. Norbert Njega, and now we're joined by Dr. Tato Musidi, who's a healthcare professional herself and is someone who will tell us a bit about her experience with MDR-TB. Welcome to Health Talk.
Thank you very much for having me.
Perhaps let's start with you. Tell us your story. You contracted MDR-TB. Tell us a little bit about it.
Well, I actually had XDR-TB.
Aha. You're gonna clarify what that XDR-TB is just
right.
now. Yeah.
So most of the people know about normal TB, which is the one that we get treated for 6 months.
Yeah.
And in the medical term, we generally call it as drug-susceptible TB.
Right.
So the other form of TB that has been on the rise is the drug-resistant TB that we talk of. And there are two broad kinds of drug-resistant TB, so to speak. The one is MDR-TB, and the other is XDR-TB, and they stand respectively for multi-drug-resistant TB and extremely drug-resistant TB. And we basically label them according to the type of drugs that they are resistant to, and also according to, it's basically XDR-TB, so to speak, is seen as more severe than multi-drug-resistant TB.
So it's the worst form of MDR-TB.
Yes.
Now, there's one aspect that we didn't talk about, and that of stigma. I see you have some charts there that you want to tell us about.
Well,
basically, maybe let's start with how you took, the fact that you were diagnosed with MDR-TB. How did you feel about it? And what do you think the community thinks about the whole notion of, TB, MDR-TB? Is there a stigma perhaps associated with this?
Well, when I was diagnosed with XDR-TB, I took it upon myself actually to speak openly about it. And there's actually lots of objection from my family and people who are very close to me because they felt I would be discriminated against if I told others that I had TB. And this is something that commonly happens in the communities. You find that there's lots of myths surrounding TB. When you hear of TB, some people confuse it with HIV and they don't really know the difference. When they see a person with TB, they think that that person is filthy or they devalue them in some way or another. So TB stigma in itself is one of the determinants that actually is driving the epidemic because people are reluctant to seek the care that they need, and they also don't complete their medication when they have already been diagnosed. So it's driving the epidemic further.
Dr. Njega, I mean, this is the area that you obviously, look at quite closely. How do we get to a point where someone has now XDR-TB? Please take us through that. And what is the extent of XDR-TB? Because we've been talking about just MDR-TB in general.
Yeah, XDR-TB, as my colleague said, is extensively drug-resistant tuberculosis.
Yeah.
This is a person who has a disease, a strain of tuberculosis that resists our strongest medicines to treat tuberculosis, susceptible, and MDR-TB, which will be rifampicin, isoniazid, an injectable, kanamycin or amikacin, and a fluoroquinolone, could be ofloxacin, moxifloxacin, or levofloxacin. It is a severe form of disease.
Do we know why it develops, though?
Generally, drug-resistant tuberculosis will develop through various mechanisms. There could be people who default their treatment. When you don't finish your drug-susceptible TB treatment, you could end up with MDR-TB or XDR-TB. So that's really, it's been the major factor. But of late, the transmission increased because as we get more MDR, more XDR in the community, we see the numbers of those that get XDR-TB and they've never had any other form of tuberculosis that is increasing. So those are some of the factors. If you share a space in a very in a poorly ventilated area, you got a risk to develop this. That's why we really encourage good ventilation, because then if you got people who are infected, they cough out, the bacilla can fly out and they pose less risk to the environment.
Okay. Dr. Vusi, we're trying to understand the risk associated with, TB and so on. Dr. Musudi mentioned HIV, the association with HIV. What is the association? In other words, of the people that we know, diagnosed with TB, how many of them also have HIV?
As I indicated, it's 62% of people who have TB are HIV positive.
Okay.
And what we then have to do as a result is to ensure that everyone who's diagnosed with TB is tested for HIV, so that then they can access appropriate care and treatment for both conditions.
Okay. So perhaps that's where the stigma comes through here.
Yes.
All right,
Yes.
because of this close association.
Yes, exactly.
Now, we learn that there's certain populations that have been labeled as high risk for TB. And these are the mining community, the prisons, young children. Please, let's go through why, for instance, the mining community is high risk.
The mining community specifically are high risk mainly because the miners who work underground are exposed to the silica dust when they actually drill those rocks underground. And the silica dust does then damage lungs if you are exposed to it over a long period of time. And as a result, then it makes the person susceptible to getting infected with TB. Now, once they get TB, they can then transmit the TB in the communities where they live. So it is critical that we actually ensure that they are screened on a regular basis, the miners as well as their families, and the community at large, because there are also other places of congregation outside the household. So that's why we're focusing mainly on increased case detection in those particular communities to make sure that people are screened, tested, and treated for TB if they have TB disease.
Okay, and then the prisons? What?
In prisons specifically, it's mainly the living conditions in prisons, in that there's overcrowding, first of all, and there's poor ventilation. And if a person comes into prison already with TB disease, which is undiagnosed, then they are likely to infect other people they are in the cell with. And therefore, again, we need to ensure that when they come in, they are screened and tested for TB so that they can be isolated and treated before they actually are mixed with the other inmates within the prison.
Yeah, all right. Okay, so how do we prevent then drug-resistant TB? Well, more on that after the break. Please stay with us.
Cameroon's economic capital, a unique art collection is on display. Titled Yesterday's Memory, Tomorrow's Memory.
We are trying to preserve this heritage despite many things that have changed in the designing, embroidery and the model.
If I'm telling you, you're gonna like it, I call it defeat.
Join Musam Khalifi on Afro Showbiz every Saturday at 19:30 CAT.
In southern Africa, a deadly strain of drug-resistant tuberculosis called MDR-TB is hitting a growing number of people. Particularly affected are people living in remote areas. In the mountainous kingdom of Swaziland, where TB is the leading cause of death, efforts are underway to bring the much-needed care to people like Kulsil. She contracted tuberculosis 2 years ago.
I was feeling feverish. I was coughing a lot.
For people here, making regular visits to the nearest clinic, often miles away, is a huge challenge.
Whether they want to reach there or not, they can't because there's no transport.
Sanil Mkonta, a nurse and head of the tuberculosis section of the local clinic, is now bringing the crucial medication to Kulsil. She's developed MDR-TB because she couldn't complete her earlier treatment. This virulent strain occurs when patients fail to adhere to the prescribed medicine, and it's more difficult to treat.
I think it's very important for us to bring the services to the people, not the people to come to us. If we can do that, I think we can eliminate it in Swaziland completely.
To improve care for the rural population, the Bafalali Swaziland Red Cross has recently strengthened its home-based care, sending nurses to people's homes, making sure that patients get their medicine and receive their treatment. Home visits are vital, believes Nathi Gomede, the Secretary General of the Bafalali Swaziland Red Cross Society.
For us, going closer to the people is the key. We also would like to provide the service at community level, make sure that our nurses are given capacity to provide testing and treatment at the community level.
Swaziland, which is one of the highest tuberculosis rates in the world, is facing a momentous battle against this highly contagious disease. Who is the Executive Secretary of the World Health Organization's Stop TB Partnership.
Do everything we can to dramatically reduce tuberculosis globally. We can do it only in partnership, and only if we can work together we can find new ways to prevent, diagnose and treat tuberculosis.
Working closely with local communities is critical in saving lives. Kulsil is getting better.
It makes me happy to know that I'm feeling stronger.
Despite hardship, the people of Swaziland are resilient. There are many who are determined to work together to beat the scourge of tuberculosis so that the children of this country can move into the future with hope.
Right. The emergence of MDR and XDR-TB has made it necessary to have decisive action from government, the NGOs, academia, the private sector, and related stakeholders. Now, let's understand from our guests as to exactly how these sectors have responded to this epidemic. We still have Dr. Lindiwe Mbusi, and we're joined again by Dr. Sarah Baba, WHO representative of South Africa, and we now have another special guest, Dr. Derek Tate. Dr. Derek Tate is clinical director of clinical development in a company called ARES in South Africa. Welcome to Health Talk.
Thank you very much.
Right. Perhaps let's start with you, Dr. Mbusi, or rather, Dr. Baba. Okay, how has the region, or how is it responding to this epidemic of MDR-TB, XDR-TB?
Well, the member states of the WHO put forward in 2014 an End TB strategy. Right. And this strategy essentially shapes everything we do in terms of the response in the region. We help governments in the region to essentially realize this vision of ending TB and having zero deaths and zero disease from tuberculosis. The strategy itself has 3 pillars. The first pillar is strengthening health systems. The second one is about having supportive policies. And the third one is related to research and innovation. So in terms of the first pillar, this involves essentially implementing what we already know works. Getting patients diagnosed early, making sure we have systematic surveillance in place, and ensuring universal treatment as well as prevention. The second strategy is about supporting policies. And so this implies that we have sufficient funding for all national TB programs. In the region, as we mentioned before, we have about a 41% underfunding of national TB programs in the region. So this is critical to make sure that these programs are funded and sustainable. The third pillar is to encourage research, new drugs, new vaccines, new diagnostics, and also looking at operational research so that when those tools are deployed, we know that they're optimally used on the ground.
I wanted to touch a little more on that, on the funding issue, but before that, let's understand from Dr. Mvusi, how has government responded to this? I mean, she mentioned strengthening of healthcare systems, and I recall the health minister, last year or so, talking about exactly that, how to strengthen our healthcare systems. How has government responded to this?
Well, as you are aware, there are initiatives to strengthen the health system, one being the primary healthcare re-engineering, and then the other initiative is the Ideal Clinic, which is being rolled out to ensure that the clinics are functional and effective. And then what is also being done in terms of TB specifically is to ensure that there's training of health personnel so that there's high index of suspicion, and we also have community health workers who would support the TB patients throughout the treatment period. We have also introduced new diagnostics like the Gene Expect that was introduced 2 years back to diagnose people early and initiate treatment early. We're improving the supply of medicines and introducing new medicines as well for treating drug-resistant TB to ensure that there's access to treatment. What we are now working on is to find more people in the communities who have TB and bring them to the healthcare services so that they are treated early. And our main challenge would be ensuring that they are continuing their treatment. But as we try and get more community health workers to provide counseling to patients and the support that they need to continue treatment, we think that the defaulter rates would as well decrease.
Yeah. I mean, you mentioned a little bit something on case finding, that we need to do more screening. I know that has been quite a problem to go out there and find cases of people that have active TB. Have we made any progress in that regard?
Well, on TB Day, the Deputy President actually launched the case-finding campaign. Within that, we'll focus initially on a few districts and ensure that people are screened and tested. And there is funding to support those initiatives. And over time, we will then ensure that we move on to ensure that all contacts, for example, are screened, as well as children specifically, the minors, prisoners, and other high-risk groups, especially people living in informal settlements. We are then hoping that from that exercise, we'll be able to then find more people and start them on treatment, thus reducing the transmission of TB in the communities. But as we do that, we also would be finding people who are at high risk of TB, especially the children, less than 5, as well as HIV positive people. Those can then have access to TB preventive treatment, which is treatment provided to HIV positive people for at least 36 months and to children for 6 months. And again, we would make sure that those that are on treatment are started on appropriate treatment if they have drug-resistant TB as well as drug-susceptible TB.
Okay. Dr. Tate, talking about prevention, the issue of the vaccine against TB has been on the table for a long time now. How far are we?
Well, we've been using BCG for 90 years now.
Right.
It is effective in preventing severe disease in children, but unfortunately does very little in adults and adolescents. So we're pushing hard now for new vaccines. We've got about 15 vaccines in clinical development at the moment. So those are actually in the clinic. of which our company is involved in partnership with other people developing 6 of those. And those vaccines run right from just into man through to a big phase 3 study, which is being conducted in China at the moment. And we've just initiated a phase 2B study in South Africa in collaboration with GSK.
But in simple terms, for the sake of our viewers, what does that mean in practical terms?
In practical terms, it means that we're still very early in TB vaccine development. And we're not going to have a TB vaccine for at least 10 years.
10 years?
Yeah.
Now that's worrying.
Yeah.
All right. And what could be the problem, by the way? Why do these things take so long?
Our big problem is we don't actually know what we need to do to the immune system to prevent TB. So we can develop vaccines and we know the person has an immune response to our vaccine. But what we don't know is whether that immune response actually protects them from getting TB. So all of our clinical studies at the moment are around trying to understand exactly what's happening to the immune system. And when we know that will accelerate TB drug development vaccine development enormously.
Dr. Baba earlier mentioned the issue of funding, funding research. In your view, do we have adequate funding? I suppose I'm asking you a silly question.
Oh, as a TB researcher, I'll always say no. But I do think the WHO and other people recognize that there's grossly inadequate funding for TB, vaccine, drug, and diagnostic research. We need a lot more. Most of the funding within South Africa is actually funded from agencies outside of the country as well, and I think it would be good if South Africa could start contributing more to this. Certainly there is more coming through via the MRC and the Department of Science and Technology, but I do think that more funding from South Africa would also be good, because the majority of our funding is overseas.
Okay, well, I'm sure they're listening. All right, stay tuned, because when we return, we now focus on treatment of MDR-TB. Stay with us.
Ja, de paar bezig. Kom.
Zoom into Africa. This is Mali. The president is Mr. Ibrahim Boubacar Keita. Mali got independent from France on 20 June in 1960. The population is more than 16 million people. One of Mali's major languages spoken is Arabic. Monetary unit is CFA.
Welcome back. Now, let's learn more about how effectively, or how this problem can be effectively managed. We still have our guest, Dr. Lindiwe Mvusi. We welcome back Dr. Tato Musidi and Dr. Norbert Njeka. But before we start our discussion, I believe we have Lerato on the line. Hello, Lerato.
Hello, how are you?
We're good. How are you, ma'am? Your question, please.
I understand that in terms of innovation, the South African government is implementing a very interesting model called community management of MDR. Could we get a bit of an understanding what does that mean? How does it work?
Okay, well, excellent question. Thank you very much. Let's get Dr. Njeka to give us a response. The community management of MDR-TB.
Yeah, thank you. Yeah, community management of MDR-TB really came as a response, and then we craft this in our policy framework on decentralization and the institutionalization of MDR-TB care. The reason why we did that is that we realized that traditionally we had to admit MDR-TB patient for 6 months, sometimes 12 months, until they get TB culture negative result. And that's really too long, very costly. And we didn't have enough bed to keep everybody. So we decided that we will look at those that are not very sick, treat them at home, start them treatment within the community, and others will get the short admission for 2 months, and only the very sick one stay longer. So within our provinces, we have areas where we have teams that visit patients at home to provide the injection. So it's a mixture of really the care, short admission in the hospital, community treatment, either with a patient going to the clinic, nearest clinic, or our teams visiting them home. So we do that depending on the need and the province, and we're really building on that. When our National Health Council approved this policy around 2011, we only had 11 treatment sites for MDR-TB in the country. To date, we have 298 treatment initiation sites, and we have 270 satellite sites. We're increasing, of course. We want all our clinics, 3,500 of them, to be satellite sites. So this is, in short, what it is.
All right. Maybe just on that. If we have so many sites, let's talk about two things.
Yes.
The treatment success rate and the treatment cure rate. How are we doing there?
Yeah, in terms of our treatment success rate, basically we report treatment success rate because it includes our cure rate and our completion rate. All these patients are successfully treated. It's just that because we treat them for 2 years, all in all, so many of them do not cough sputum at the end. We do not have the laboratory result indicating that. But the success rate is sitting at 45% for the cohort of 2011. It takes long to analyze this. We're busy looking at the 2012 now to be reported in May to the World Health Organization. We're now sitting at 45% for MDR-TB. For our drug-susceptible TB is nearly 80%. So there is progress around that. We used to have lower cure rates than that. We come from far. Yes.
Dr. Vusi, perhaps, still on the issue of rates now. Do we have targets that we set ourselves, and how are we doing against these targets?
Yes, we do set targets in the National Strategic Plan for 2012 to 2016. The target for end of 2016 for cure rates for TB is 85%. And as it was indicated, we're at 78% currently. So we're hoping that with all the strengthening of the programs that and the interventions that we're putting in place now, we will be able to reach that 85%. But we are also now setting targets beyond the 2016 to 2025, where we hope that we would have more than 90% cure rates.
What do you think, I mean, the case-finding initiative will have on that cure rate? Because I would imagine the more people you go and find and you put on treatment, it might have some impact. Well, hopefully not a negative impact, but what's your view?
Well, yes, we do anticipate that doing that might reduce our achievements currently.
Right.
Hence, we need to ensure that we strengthen the health system as well, so that we don't then reverse the gains that we have achieved up to now. So there are plans to ensure that as we get more community health workers, as I indicated, to support those patients that are on treatment so that they complete their treatment.
Dr. Musidi, she's just mentioned patients completing treatment. We know that with, susceptible TB, as you described it, if you take your treatment for 6 months, more or less you're fine. But with MDR-TB, you have to take treatment for a long time, and compliance becomes a problem. You deal a lot with, patients that are taking treatment. You encourage them. What is your view in terms of, compliance to treatment, especially in cases where people have to take treatment for a long period of time?
Obviously, the length of treatment does play a huge role in this part compared to drug-susceptible TB. We are comparing 6 months to a minimum of 18 to 24 months. So yes, adherence is very important, and it's a message that we should continue to emphasize that patients should adhere to their medication and complete the treatment. Having said that, obviously it's very difficult, you know. I've done it myself. I'm still currently in my treatment phase, and it takes lots of support, you know, support from family, support at work, support everywhere where you can, you know. And that's also one of the things where we talk about stigma, because if there's so much stigma, then where do you get the support from? Because nobody talks about it. So what we try to do is to get patients to disclose, you know, so that the more they talk about it, there's other people who can help them. With drug-susceptible TB, we had the DOTS program. You know, for MDR, it's also the same principle where you can have somebody else that you've disclosed to, and they help you get through your treatment.
And what sort of support is then given to those around the infected patient, if you can call it that?
The local health facilities have always got support. If patients have any problems with their medication, patients are free to go there at any time. Again, we try to also form support groups in the form of adherence clubs in the communities, where you find a number of other patients who are also on TB treatment, and you can go to that support group, talk about your medication, how to work through the side effects, what to do when you have side effects, and we've seen that that also helps patients a lot.
Yeah. Perhaps last word from you, Dr. Mvusi. In terms of access to treatment and availability of treatment, is that an issue at all?
Well, fortunately, we don't have a problem in ensuring access to treatment. People have treatment, can get treatment in any clinic. The only challenge is that people do not then complete their treatment. And that then is what results in drug-resistant TB. We have currently introduced the new medicines as well as for drug-resistant TB, which are accessible for those patients who need to actually go on to that treatment.
There was talk of, you know, new drugs being available that, you know, work best for MDR TB and them not being accessible and so on. Is that sorted now?
Yes, the new medicines are accessible. Our first patient to receive, to swallow the first set of tablets was in Uppington on the 20th of March. Remember, we had a clinical access program for 200 patients, which we exceeded to 211 patients. After that, the medicine bedaquiline got registered. We're scaling up to 3,000 for year one, and that will represent 25% of our MDR XDR TB population for the whole year, because we've got approximately 12,000 every year. So the medicines are available. 3 to 4 provinces have already received the first consignment. Patients are taking bedaquiline. Linezolid is also registered. Some of them have received linezolid. So these are 2 new powerful medicines. And we take this as an opportunity to address the problem of hearing loss. A lot of our people out there lose hearing after finishing MDR treatment because of the injection, kanamycin. Okay. So we've rolled out portable audiometers, and those that will be found to have problems with hearing will not be given an injectable among our MDR TB.
I'm
afraid
afraid
be given bedaquiline.
Yeah, we're just going to have to leave it there because
Thanks
we're
a lot.
out of time. And yeah, Dr. Lindiwe Mvusi, Dr. Tatu Musiri, Dr. Norbert Njeka, thank you so much for your time.
Thank you.
Thank you.
All right, it's on that positive note that we come to the end of our show today. Your views and comments are extremely valuable to us, so please share them with us on our Facebook page, SABC Health Talk, and like us, and follow us on Twitter at SABC Health Talk, and drop us an email at healthtalk@sabc.co.za. And of course, join us again next week, same time on SABC News. And remember that you can watch repeat shows at 2 p.m. and 10 p.m. And if you've missed any of these shows, you can always get them from the YouTube channel. So for myself, Dr. Slovo Daung, and the rest of the crew, goodbye.
Thank you.
Thank you.